maxillary teeth. Reaching around the patient with a thumb and index finger, we can hold the tray over the bicuspid areas. The next step is to hold the thumb against the lower teeth and slowly, don't bite, please, slowly bring the jaws together. Open, please. As soon as the patient touches the compound, we ask them to open, please, and then we can take the tray out of the mouth. We have a retruded index of the lower teeth. We take it then to the cold water and harden the compound quickly. Okay, you can fade away. After the compound has been hardened in the cold water, we take the sharp scalpel and trim back the excess over the lower incisors until we have less than 1 millimeter of tooth substance into the compound. Just a very small index. All right, after the compound has been trimmed back, we put the tray in the mouth and position it over the teeth exactly like it was originally. Hold it against the maxillary teeth, guide the jaw up slowly in a retruded manner, and see if the teeth are in their most retruded position. Tap, tap, tap. Stop. Now we allow the patient to do it without our hand on the patient's jaw. And we can see that the patient can continue to come into the same position repeatedly without strain. All right, we now know that we're at the most retruded position of the teeth. We want to see if we have clearance of the posterior teeth with the tray. Just bite and hold tightly, and we see the ribbon sliding out. Go to the left, bite straight down, and the ribbon is totally free, so that we know that the posterior teeth of the lower arch, open please, are not touching the tray, because we cannot have any lower tooth contacts with the posterior part of the mouth. We can only have the anterior teeth touching the compound. Now the important thing is that we dry the tray very well with compressed air before we put our noginol on the lower side. We usually have to put more noginol on the lower side because there's a slight opening of the bite than we do on the maxillary side. On the maxillary side, it's all right if the teeth touch the tray, but on the mandibular side, we cannot have the teeth touching the tray. We now take it to the patient's mouth and gently reposition it over the maxillary teeth, just like it was, and then we ask the patient to bite their teeth together, bite right into it, and they will go right into the centric record without us putting our hand on the patient's chin. In other words, they have learned already where their retruded position is. And as you can see, there's no muscle strain on the patient. We simply hold the tray against the maxillary teeth with our index fingers, and our other fingers usually rest just along the lower border of the mandible. We instruct the patient not to clench the teeth, but just to bite with light pressure against the compound index. If the patient should clench the teeth, they might flex the tray, flex the mandible, compress the disc in the temporomandibular joints, or intrude the lower teeth into the alveolar, into the periodontium, and all of these things could create an error in our record. After the noginol has hardened, we hold the tray firmly against the maxillary teeth, usually with our middle finger and index finger to give it good support. Hold it firmly against the maxillary teeth and ask the patient to open the mouth. then we can separate the tray from the maxillary teeth, and that way we usually don't warp it. Now we can see excess material here. We must shave that back before we can use this tray for mounting casts. After the material is hardened, we can shave it back with a sharp scalpel knife. All right, we're now ready to take the protrusive interocclusal record, and as you remember, the maxillary side is exactly like the tray we used for the Centric record. The tray must be dry, and we heat about 3 centimeters of the compound, very hot. When the compound begins to slump, we bring it over to our tray, putting it well out toward the anterior flange to catch the lower teeth when they go forward. We have plenty of working time for this. We can temper it in the warm water for just a few seconds, and then take it to the patient's mouth. We place it gently over the maxillary teeth and fit it against the teeth exactly like it was originally. Hold it there with our index finger and thumb over the bicuspid area. Then we hold the lower teeth back, retrude it, go up, and make a centric index. Open, please. I'm going to warp this compound a little farther forward now. We'll go back, bite in retruded position, in centric. Open, please. Now, with the mouth open, slide your jaw forward, way out, come up and touch into the compound. Open, please. And then we take it out of the mouth. Now, what we're looking for here is about 5 millimeters of protrusive movement. That's why we made the retruded index and then came forward and made the protruded index. Following that, we take it back to the cold water and harden it. Right? After the compound is hardened, we must replace it in the patient's mouth and test to be sure that the patient isn't making any posterior contacts. Can you bite forward, bite out forward in protrusion, way forward, there. And we must make sure the ribbon is sliding between the posterior teeth. Bite forward again, in protrusion, find your index, and you see the teeth are free. All right, we now look at this once again and make sure that the protrusion is at least 5 millimeters from the retruded position. We usually use a bully gauge or a small ruler for that. Do we have a bully gauge or a ruler that we can use? All right. We can take a small ruler like this, a millimeter ruler, and we can measure to see that we are at least 5 millimeters in a protruded position with our protrusive check valve. All right. We now put our conogenol on the lower half, and because the separation of the posterior teeth is usually greater in a protrusive position, we have to add more than normal amounts to the lower half. Take the tray to the patient's mouth and position it over the maxillary teeth exactly like it was before, and then we instruct the patient to bite forward and bring their teeth together and find their, not so far, and find their index right there. we have the patient bite into the protruded index without a lot of pressure, and they hold in that manner until the ZOE has hardened, and I hold the tray against the maxillary teeth to keep it from coming down. We now have to take our centric record after the mandibular side has hardened, take a sharp scalpel and trim back the excess so we have only the cusp tips in the impression. It must be now washed off and blown off so that all the particles are removed. After the centric record has been thoroughly cleaned of all the loose particles, we must try it back in the mouth again, hold it against the maxillary teeth, and then have the patient retrude the jaw, come up, and see if the entire bite is correct. And I take the glasses, look very closely to see that the lower teeth fit very, very closely into the indentations, and we see a perfect fit. Open please, close the teeth again. It goes exactly in the same place, and the teeth are actually fitting the centric record with absolute perfection. Open please. Now we must take this back to the models and find out if the models are accurate. And our proof for that is whether the model fits the index in the ZOE exactly like it does in the mouth. This is the proof of whether our alginate impression or whatever impression we have and the stone cast is as accurate as the mouth. And if we see that the cast fits perfectly to the record, then we know that the cast is an accurate replica of the mouth. And in this case, it looks very, very close. So we can accept these casts as a close replication of the mouth in centric relation. We must now take the bite fork and trim back the excess amount of ZOE so that our cast will fit perfectly. We only need about one tooth to support the cast. Just a small area. And in the anterior region, we need to cut that back so that we have just a small supporting area for the cast. This must be brushed clean with a toothbrush or blown with compressed air. The next step then, before we can mount these casts in the laboratory, is to fit the maxillary cast into the index on the bite fork and make sure that it fits perfectly. In this case, we see a perfect fit, so we can take the casts and the bite fork and the protrusive and centric record to the lab. Review the 5 items that we take to the laboratory for mounting the casts and adjusting the articulator. We see here the centric and protrusive records. If you'll notice, they've been put in plastic bags and sealed with cold sterilizing solution on gauze pads. The other items are the accurate mandibular cast and the accurate maxillary cast, which have been tested for accuracy with the centric record. And the 5th item is the bite fork assembly for mounting the maxillary cast on the articulator. Facebow is cast mounting procedure with detachable bite fork assembly and centric relation interocclusal record. Panadent articulators routinely come from the factory with 1.5 millimeter motion analogs, average value. However, the Bennett size and angular rotational setting is not important for mounting procedures since motion analogs are all interchangeable in centric relation. Be sure that the mounting plates are tightly positioned on the articulator before mounting casts. Before mounting the casts, check the manual on figure 96, and the best way is to loosen this set screw right here, which locks the analog, and then loosen the thumb screw slightly. Rotate the motion analog up to number 6 setting, which is right there, and then lock the thumb screw. Then we go back and lock the set screw like this. Let's come to the other side and repeat the procedures. Loosen the set screw, then loosen the thumb screw. Now we can rotate the motion analog to number 6 setting, which is right there. We can lock the thumb screw to hold that position, and then come back and lock the shaft. Now set the incisal pin at the heavy engraved ring. This will make the articulator frames parallel to each other. Here you can see that the frames are both parallel to each other. Notice also that the rounded end of the incisal pin is touching the plastic incisal table.